look like with the sheath across.
Mario, good morning.
Hello?
Mario and...
Hello, Carlos.
Vivo.
Good morning. Can you hear us?
Yes.
Yes. Can you enlarge the field? Okay. Hi, everybody. We are here in the cath lab in San Donato. On my right, you see Jacques and Luca and the other guys there. And the patient we have on the table is a 3.5 years old boy with a muscular VSD, and Angelo Micheletti in a second will present you the case. Please, Angelo, go ahead.
Yeah, go.
Angelo, you're on.
Yes. Good morning to everybody. This is a 3.5-year-old child. He has been followed up since the first month of life for a muscular ventricular septal defect. He is growing well with normal development. His body weight is about 19 kilos. On the echo, you can appreciate some degree of left heart volume overload. And this is the short axis view showing the muscular restrictive VSD just in front of the moderator band. In the four-chamber view, again, it seems like a double jet divided by muscle bundles by the moderator band. The pulmonary artery pressure is normal. All the valves are well functioning.
Okay. Can you get back to me? Can you get back to me? Well, on the echo machine, we have Wayne Trureski. Good morning, Wayne.
Good morning.
Together with Javier Fernandez and Francesca. So, Wayne, if you want to make some comments, some consideration of the anatomy, please.
Sure. So it looks like the VSD on the left ventricular side.
You want to see the echo pictures,
Yep.
please, on the screen. Okay, good.
So on the left ventricular side, can we go to the VSD measures about 5 by 5 millimeters in 2 different planes, and as Angelo said, it looks like it splits into 2 on the right ventricular side around the level of the moderator band. All the valves otherwise function normally, and it looks like they have good wire position. It looks like the wire's through the more inferior part of the defect on the right ventricular side.
So shall we show you what we've done so far? The pulmonary artery pressure is about 27 systolic compared with the aortic pressure of around 90. Mario's done a saturation run, and the QPQS works out at about 1.7, 1.8 to 1. So normal pulmonary artery pressures. Angiographically, the VSD will show you an LV angio in a second. Here we go. Oh, that's the pressure trace.
Okay, you see the angiogram, yes? Right. Yeah. Here, look at this.
Okay, so you see the LV angio, and it's sort of a mid-muscular VSD, which measures around 5 millimeters at the 5 to 6 millimeters at the left ventricular end, and we don't see the 2 openings at the right ventricular side because of the muscle bundles, but on TOE we've seen that. Next. So any thoughts from Carlos?
Next.
It's a very, very nice imaging, both from the echo as well as from the angiograms. It shows very clearly that mid-muscular VSD. So tell us, what is your plan? You're obviously, we're already seeing that you're trying to cross from the left side to the right side.
Yeah, that's right. We enter from the left side to, well, trying different catheters, right Judkins, cut pigtail, and eventually right Amplatz was the best one to enter the VSD. Advance the exchange wire to the main pulmonary artery, snare it, and make a circuit. So now we have a circuit, and I show you live the fluoro.
One of the quick discussion points was whether to approach this defect from the femoral venous side or the internal jugular.
Yeah.
And Mario and I decided for the internal jugular, but from your side, anybody would approach this from the femoral venous approach?
Well, I think one of the big questions here is not only where you're gonna put the device, I think the most important thing that I can see here is that you want to make sure that you don't entrap any portions of the chordae of the tricuspid valve when you advance. So tell us, how did you get into the pulmonary artery? You use a balloon tip catheter to get into the pulmonary artery to ensure that there are no passage of the wire that you want to snare and to create the rail through the tricuspid valve and ending up with some problems in trapping the tricuspid.
Actually, Carlos, on echo, there is no any evidence of tricuspid regurgitation. Advancing the wire of the sheath, there was no feeling of any tension, so I feel quite safe.
From the internal jugular, Mario went in with the J-wire as well, and it just made its track very easily across into the pulmonary artery. So
that was a smart wire.
Yeah, it was a very smart wire.
And are you using the noodle wire to rail out?
No, that's a standard exchange wire.
We used a Terumo.
The Terumo wire.
Yeah, yeah.
So the glide wire.
Yeah. So if you have a look now, can you show the fluoro? You see from the internal jugular vein, the 7 French flexor sheath advancing through the hole and is up to the aorta. And you have a pigtail in the left ventricle.
Okay.
Okay, so shock.
So we were trying to work out from the measurements what type of device...
Wayne, any consideration on the size that you're suggesting, what device and what size to use?
Well, the maximum we get, the 2D measurement on the left ventricular side is 5 by 5 millimeters.
5.5.
Okay. So Carlos, I know it's early in the morning for me and I can't think, so I need some help, or Mario and I. When I came here at the hospital, Mario was still asleep. So we had to wake him up for this case. So neither of us are thinking very well. So can you help us with type of device, size of device?
Yeah, I can bring you some ristretto coffee to wake you up. That may help you. But what device size would you choose?
Well, we're asking you for help.
What's the measurement on the LV side?
5.5 at most.
I would use probably a 6 millimeter VSD.
And what type of device?
Muscular VSD. You could use either a muscular VSD. You could use also a PDA device if you're coming from the right side delivery.
Yes.
So either one of those would work well.
Right. Actually, well, just to make it sure we were a bit late, actually, we agree with you. We already selected a 6 millimeter muscular VSD occluder. So if you agree, we carry on and show you the device, load it, and put it in the heart. Okay,
I think
Carlos?
it's a very sensible choice.
All right, good. Okay. Let's get close with the camera. Yes.
We need the delivery cable.
Then we'll delivery system. Say? Chuck, go ahead and show it. Okay. You can look at this. And they have, they are looking at these pictures.
Okay. So what you can see...
Chuck, you should clean your...
All right. Okay. Mario's trying to make me clean my hands and get rid of the blood. So here you see an Amplatzer muscular VSD device with this has got the 6 millimeter waist, and here's the screw end, and that's the hub which will be at the left ventricular side. The discs on this are 10, aren't they? On the 6 millimeter.
Yes.
So the left ventricular
5 millimeter on the left side and 4 on the.
Yeah. So the discs. So here the left ventricular disc is going to be 11 millimeters, I think, and the right ventricular 10. It's the usual standard Amplatzer muscular VSD device, which we will load when we have a delivery system ready. Okay.
Well, actually, we are not going to use the standard delivery sheath from St. Jude because we already inserted a flexor sheath. And in addition, this may be useful for the audience. We kept a coronary wire, guide wire on the circuit just to keep the circuit, just in case we lose the position, etc. So we will have a coronary wire in the sheath, crossing the VSD and going down to descending aorta. And now we are going to load the device, which could be fit into a 6 French, but you have a 7 French,
Yeah.
so we can keep the wire in position, right?
Yeah.
So now, yeah, Jacques.
So it's a quite a challenge here because Mario can't see. He hasn't got his glasses, and I've got my glasses, but they're varifocals, which are slightly old. So we're really just working by feel. And that, oh, I seem to have attached it.
Well, Carlos, you see the device in Jacques' hands. But
Very well. Very good
Yeah.
close-ups, yes.
yeah, but in fact, I advanced the wire to load it because he couldn't screw it up.
Now let me ask you, there are two types of cables released. You use the standard cable or you use the thin cable?
We're using a standard one.
Okay, do you find that this is perhaps less conducive to self-adapt the positioning of the VSD device through the VSD because of the force that the cable has as opposed to the thinner cable?
We will see in a second.
Yeah, we'll see in a
Jacques.
second. I think that's an interesting point. It is a sort of more rigid one, so yes, I agree.
Wait a second.
Oh, right, hold on.
Jacques, wait a second, please. Can you see with the camera the hands here? There. Just to show you, well, maybe Luci su? Oh,
So you're using a
that's
flexor
okay.
sheath.
That's a flexor sheath. And you see
Yeah,
the
that's a
coronary
flexor sheath.
wire inside.
Right.
Okay? And Jacques will advance the
Is that an 014 or 018? 014.
014.
014.
Yeah. So Jacques will insert the dilator. We have space enough to advance it. Hopefully. Yeah?
Yeah.
All right. So that's good. Luci giù. Let's go to fluoro and echo picture in picture, please. Para 15 a 15. I step on floor for you, Jacques. We can do a magnification, probably can see better.
Now, what angulation do you have on the fluoroscopy?
That's the LAO 40/20 cranial.
Okay.
Jacques, go ahead.
Yep. So now we've got the device somewhere up in the aorta. We've got the TOE picture in the way at the moment.
Go for
TOE probe in the way.
Okay.
Just a little. So
You wanna
if you could pull the
keep
TOE back just a little bit for a few seconds. So now I'm just coming back
that's in the aorta.
in the aorta. So I'll keep a little onion and let it drop down.
Yeah.
Mario is going to keep the coronary wire
Yes.
in place, which
We
is
go to
down in-
LV. Yeah.
yeah.
Should I go down,
Yep.
Jacques, for you? Okay. So you trans. Yeah.
Okay, so
Store
store
fluoro.
that. Now if you could have a look with TOE.
Yeah. Can you see the echo large, please, on the screen?
Very well, yes.
Echo
Very
large.
nice echo images, yes.
right.
So on this, I made an onion of the device rather than a full disc. Let it drop through the aortic valve and then very quickly open the left ventricular disc up. So now I'm just going to pull back onto the septum.
So it looks like the mitral valve function
Is good.
I will move the pigtail from there for a second.
Yeah, just
a little bit of
We will center a bit
passive mitral regurgitation.
better.
there's what?
Okay.
There's a little bit of mitral regurgitation.
Okay.
Well, that's tension.
Yeah.
We can do
So
a
should we do a quick angio?
angio. Keep the floor up for a second. Okay.
So how close is it to the septum? It's at an angle, isn't it? Okay, so we've
You're
got a
far
way.
away, yes?
We've got a way to go yet. Okay, fluoro.
Well, there is a tension partially due to the coronary wire we have in the circuit as well. Anyway, you want the story pitch? The story
Mario?
picture?
Yeah.
Good morning, Mario.
Good morning.
Dietmar here. I have a question concerning the good idea of the wires, the coronary wire and the descending aorta, but crossing the aortic valve. And when you open the device in the ascending aorta, I got a little bit...
Just wait a second, please. Let's just do another quick angel.
Okay, but I thought you have two brains.
Inject, okay. Okay, I think the device looks okay, Jacques.
Yeah.
Sorry, Dietmar, we are in
No problem.
Okay. All right, so the device is open. I think we are doing...
Store that.
Yeah, store, and we do a proper angel.
Now, Wayne, have a look.
So that looks pretty good.
Let's have a look. Well, let's do an angel first, then we
Let's just look
check
at the
on echo.
tricuspid valve.
Okay?
So mild, it's probably because the sheath is crossing the
Okay.
tricuspid valve.
Okay.
On angiography, looks very nice.
Now,
So
Dietmar,
have
what
a
was
look
your
at
question?
echo.
Let's just look
Yeah,
at the 2D
Dietmar,
of the
we are
valve,
back to
so
you.
Yes.
It's not distorted.
Sometimes I'm using a wire when I have not a cutting balloon for cutting a structure. So my question came up when I saw your wire in addition to the device in the ascending aorta, and I thought, could it be that the aortic valve could be damaged by the wire?
Yeah,
That's my
we will be
question.
very careful. Now we will remove the wire. You Jacques, we keep it there. I remove the wire. You have to do this.
I'm doing it.
Yeah.
So, fluoro.
Dietmar, I'll tell you most of the time that could be a possibility if you use a standard wire. If you use glide wires, that would be very almost unheard of.
There we are.
Okay.
Store
That
that.
looks good.
Did you see the wire, the coronary wire coming out?
Yes.
Yes. So let's check by echo now the position of the device, the function of mitral valve, any entrapment on the tricuspid or something. Okay, Wayne,
So
any
there's
comments on that?
There is this mild tricuspid regurg, but it's probably because of the,
Well, we have
sheath across
yeah,
the valve.
we have the sheath
Yep.
across it.
And the mitral valve, there is really just trivial mitral valve regurgitation. But it looks like the device is far away from the valve. The valve looks okay by 2D.
Okay.
Let me just push this sheet down a bit.
Wayne, do you agree we are going to release the device?
Yes, we don't see any flow across the VSD. Actually,
Okay.
and, it's in good
So
condition.
if you don't mind, in the audience, we're going to release the device. Jacques?
Yeah, go ahead.
Okay.
Looks very good, Mario.
Okay.
Okay, store
The
that
wire out.
and flush
So
them.
far. Okay.
And then angel.
Okay. Let's do a quick angel. 25 F15. Well, the position of the device looks okay. The shape of the two discs are also okay. I think it's going to be okay. Now we do an angel, then we will have a look at the echo. Okay.
Looks pretty perfect to me, if I say it myself.
Right. Thank you, Sean.
Wayne, what do you think?
It looks really fantastic, yeah.
Yeah, it looks pretty good. The
So
3D
now
valves look good.
Now the sheets are out of the tricuspid valve and
The
catheters.
tricuspid valve looks perfect.
Yeah.
The device is in good position. We don't see any residual VSD flow. Mitral valve looks good.
Yeah. Okay,
Got a
Carlos,
short
any,
axis also.
and there's no aortic regurgitation for Dietmar, if
Now let's look at the aortic
you could
valve.
let him
Looks
know.
very good. The mitral and
Well,
tricuspid
we still-
valves are
we still
fantastic. I think you guys did a great job.
So
Okay.
Congratulations.
Okay. So, yeah. Okay.
We're
Bye-bye,
gonna be
everybody.
moving.
We'll
We're
catch you
gonna
up
leave
in
you.
the
We're
conference
gonna
room. Thank you.
move to Naples.
Well done.
Next
Thank you very
is
much.
we're
The
gonna
pigtail out.
connect us onto Naples. Good morning. Hello, can you hear us? Yes.